Hi, this is Dr. Lehman, and today we're going to be talking about bone disorders, mostly osteoporosis, but we'll spare a few words for osteonecrosis, osteomalacia, and rickets, Paget's disease, of the bone, osteopetrosis, and osteogenesis imperfecta. So the main objectives, I'm just going to review briefly bone metabolism. I'm going to focus on osteoporosis. I want you to know the underlying pathophysiology, the clinical impact and presentation, screening guidelines, that's important, the approach to prevention and treatment, and then again a few things about these other bone disorders. Which of the following do you think is true regarding osteoporotic bone? Do you think that the ratio of osteoid to hydroxyapatite is increased? Do you think that the collagen matrix is structurally impaired? Do you think it has lower density than healthy bone? Or do you think that calcium loss from osteoporotic bone results in plasma hypercalcemia? Over the next few slides, I want you to keep this question in mind, but I'll tell you right off the bat, the ratio of the cells to the crystal, to the mineral crystal structure in osteoporosis is maintained. The collagen matrix being structurally impaired, that's things like osteogenesis imperfecta. The lower density, that's actually the defining feature of osteoporosis. And the calcium loss from osteoporotic bone is managed by multiple mechanisms within the blood to keep the calcium level within the normal range, and we'll talk about that. So this is normal bone in the middle of the screen, osteoporotic bone on the right, and what we know is that osteoporotic bone has low mass. The mineralization to osteoid structure is normal, but the architecture, in addition to just being low mass, the architecture is somehow disrupted as well. So there are a few different definitions of osteoporosis. The NIH says that it's compromised bone strength that predispose to an increased risk of fracture. And I kind of prefer that definition because it's the functional definition. I'm not so interested in just the state of your bones. What I really care about is a clinical outcome. So if you're at increased risk of fracture, that's much more important to me than this World Health Organization definition of an actual test result that falls 2.5 standard deviations below the mean for young healthy adults of the same gender. That means a little bit less to me than the fact that there's significant morbidity and mortality associated with osteoporosis. The common way to talk about it, perhaps with your patients, is just to say brittle bones. So back to that World Health Organization metric, we're talking standard deviations from bone mineral density of gender-matched healthy young adults. And if you're within 1 to 2.5 standard deviations below what's normal, we call that osteopenia. If you're greater than 2.5 standard deviations below what's normal, we call that osteoporosis. Why do we care about osteoporosis? Well, it's prevalent, it's painful and disabling, and it's costly, but most importantly, we can actually do something about it. So the epidemiology, couple words about this. 8 million women, 2 million men meet the criteria. Many more have decreased bone mineral density and are also at risk for fractures without actually meeting the criteria for osteoporosis. So about 1 out of every 2 white women will have an osteoporosis-related fracture at some point in her lifetime. It's very significant. $18 billion a year. Here are some of the morbidities and mortalities associated with osteoporosis. So radial fractures, almost 500,000 yearly. Hip fractures, fewer yearly, but significant morbidity associated. So you get a hip fracture, you're more sedentary, you're predisposed to venous thromboses and pulmonary emboli. 50% lose mobility permanently. Once you have a hip fracture at an advanced age, 20% will be dead within a year and 20% will be confined to a long-term facility and will not be able to live independently from there on out. Vertebral fractures, 700,000 of these yearly. So when you see those little hunched over older ladies and men, it's not that they have bad posture. It's likely that they've had some vertebral compression fractures that are causing a number of sequelae. You see height loss, you see that kyphosis. Think about what's within that rib cage. It's your lungs. That's giving pulmonary restriction. You're more at risk for atelectasis and even pneumonia. In the lumbar region, you're seeing compression of the abdominal organs, leading to constipation and appetite loss. So when we're talking about fractures, there are important, the density of your bone is really important, but there are functional factors that are equally as important, if and arguably more important. So the fact that distal radius fractures increase in frequency approaching age 50 but plateau by age 60, while hip fracture incidence doubles every 5 years after age 70, tells you something really important. When you're younger and you have a fall, you get your hand out there in time to break the fall. When you're older, the reflexes are slowed and you're even more susceptible to falling right on your hip. The functional factors that play into whether you're going to even have that fall in the first place, I think are very important. So things like vision, motor strength, the quickness of your reflexes, all of those are really important. So is your balance impaired? How's your vision? How's your hearing? Are you strong? Are you agile? Do you have any other complicating medical conditions? Age is a really important fracture. You can see how the risks of any kind of fracture, hip, radial, all of it, significantly increase as your age increases, especially beyond age 70. So here's a question. Both hip and vertebral fractures lead to decreased mobility. Consequences of immobility include all of the following except: do you get constipated with sedentary lifestyle? Are you at risk for deep vein thromboses? Can you get a pulmonary embolus as a result of the DVT? Fatal hemorrhage or pulmonary infection? For me, fatal hemorrhage doesn't seem to be an associated risk with immobility, but all the rest of these are, and that's very significant. Okay, let's take a small detour and talk about bone histology and physiology. It's so interesting. I love a total sucker for SEMs, and this is a really beautiful scan of there's like a composite that's forming the scaffold, and then there's osteoblast cells seated onto it. So this isn't an actual bone, but this is what bone will look like microscopic. So big picture, functions of bone. We always think of it as like the skeleton, right? We think of it's a place for muscles to attach. The rib cage is protecting the organs inside. All of that stuff is happening. But another really important function of bone that you'll definitely learn more about in the endocrine unit is that it's a hemostatic reservoir for calcium predominantly. Calcium balance within the blood is critical to body functioning and life. So it's a really important system. There's lots of controls to ensure that calcium stays right in the correct range. It's also a reservoir for other minerals as well. Bone is not just that sort of inert skeleton. It's very dynamic. So I like to think about the ingredients in bone as sort of the trimurti. You've got the creators, the osteoblasts. You've got the osteocytes that are kind of just there being bone. And you've got the osteoclasts, the destroyers of bone. They're not necessarily villains. Sometimes it's good for there to be turnover of these bone cells. Sometimes they're old and they're damaged and they gotta go. Besides the cells, that living dynamic stuff, you've got this extracellular material. So you have this sort of scaffolding, this matrix made mostly of collagen It's called osteoid. So those are the fibrils that you saw in that scanning electron micrograph before. And then there's this solid mineral phase that's made of calcium and phosphate hydroxyapatite. That stuff, to me, it's like, it's kind of sci-fi. So you have the appropriate cellular milieu, you have enough of the ingredients, and then in this sort of nanite kind of way, these crystals just form. If it's the right pH and all the ingredients are there, you're going to form this solid mineral phase all around this collagen matrix. The cells will be there doing their work, and you'll have this dynamic bone tissue. There are a lot of other minerals that are important to think about. We always talk about calcium, but please recognize magnesium, strontium, and the rest of this list are also important components of bone, and so important components of our diet. A word about bone metabolism. So we've got the 3 phases. The phase where you're creating your bones when you're a fetus. The phase when your bones are growing and modeling as you're a growing child. Once you're an adult, your bones are just kind of there, right? No, they're constantly remodeling. There's this ongoing balanced action between osteoblastic bone formation and osteoclastic bone resorption. Why would we have this going on? Because we live in a world that's hard. And there are lots of sharp corners and falls and little micro traumas that happen to us all the time. I find it fascinating that radioisotope studies show we turn over as much as 18% of our total skeletal calcium every year because of adult bone remodeling. This is the classic bone remodeling unit. I think Dr. Lin will speak about this a little bit more. It just illustrates what I was talking about with the osteoclasts eating away, osteoblasts coming in and building up new bone. So the absolute mass of the bone can tell us a little bit about the actual strength of it. We know, though, that too much bone mass is not necessarily a healthy bone either. We'll talk about that when we get to osteopetrosis and Paget's disease of the bone. The tensile strength comes from the density of the mass as well as the bone architecture. If that remodeling is happening in the healthy way, the new bone will be healthy and strong. If that remodeling is compromised in some way, it can lead to poor structural quality, even if the bone density is maintained. So the picture isn't as simple as it's sometimes made out to be. Something that's important that I wanted to point out to you, because this has clinical impact, is that there are serum and urine markers of bone turnover. So the end telopeptides of collagen are called NTX, and we can check urine for the quantity of that to give us an idea. Is the bone turning over at the rate that we'd expect, or at an even higher rate than what we'd expect? And we'll come back to talking more about urine NTX in a bit. I also just want to remind you that we have cortical bone that's compact, and we have this cancellous or trabecular or spongy bone in the center. It makes up, it's found at the ends of long bones and the greater part of cuboidal bones. It's a lot of surface area in that cancellous spongy bone, so we know that that's the most metabolically active part. And that's where bone loss occurs in osteoporosis, and these are especially areas that are vulnerable to osteoporotic fracture. So we see them in the vertebrae, in the femoral neck, and in the distal radius more than anywhere else. So this is an illustration of a classic one night on call on a big internal medicine service, and you will admit at least one femoral fracture at the femoral neck specifically. So I talked a lot about how bone is remodeling all the time, and that's a good thing, as long as it's happening at a good pace and in response to the correct stimuli. So what are the forces regulating this remodeling? You'll get more about this in endo unit, but I really want to introduce you to a few hormones that are most active in regulating bone remodeling. These are PTH, vitamin D, and calcitonin. And I will say a word about the rank cellular signaling systems and leave most of it to Dr. Lynn because she'll talk about it too. What I do want you to recognize, though, is as soon as we're talking about regulation, that's the moment where that's a place that's susceptible to intervention, therapeutic intervention. So the rank ligand story, basically you have pro-resorptive factors that favor activation of osteoclast activity, and that's mediated by rank L. Prolia, or denosumab, is a monoclonal antibody that inhibits the rank ligand. So this is just a big picture slide illustrating all the interactions and the complexity of them between all the factors that are influencing bone resorption through the activity of osteoblasts and osteoclasts predominantly. And I think you might find this picture useful after Dr. Lynn talks to you more about these factors. The ones that I really want to talk about are just PTH, vitamin D, and calcitonin. These are the main actors that are affecting calcium homeostasis. Here's how I think about their activity. I think of PTH and vitamin D as friends. They both increase calcium, whereas calcitonin tones it down. And PTH and vitamin D, well, they're doing the same kind of thing. What's the difference between them? PTH is the twitchy guy. He's the one that gets in there right away. Hey, calcium's low. Let's get in there, increase it, or we're going to have a seizure right now. Vitamin D is the slow and steady. He comes in after his friend PTH has done his work, and he's like, hey, calcium got really low. That was sketchy. Let's make sure it doesn't happen again anytime too soon. Let's take in more calcium from the gut. Let's retain more calcium in the kidneys. Where did PTH go to get his calcium before you had a seizure? He was willing. He thought getting your blood calcium level up was so important. He was willing to take it from your bone. He was willing to take it from your bone. You can imagine if PTH, say you had a PTH tumor or your parathyroid glands were making too much of that hormone, you can imagine they would just be busy taking calcium from your bone all the time, and eventually it would put you at risk for osteoporosis. And not just osteoporosis, it would put you at risk for hypercalcemia. That's how we would detect your hyperparathyroidism. So, the parathyroid glands are like a calcistat. They have a way of monitoring what the calcium levels are in the blood. If your calcium level is low, PTH comes out like the wolf. He increases your resorption from the most important thing that he does is he mobilizes your calcium from the bone. So anything that increases PTH activity is a risk factor for osteoporosis. That's primary hyperpara and secondary hyperpara. The role of vitamin D, this promotes calcium and phosphorus absorption from the gut and from the renal tubules. Anything that disrupts this activity of vitamin D puts you at risk for osteoporosis. So you're not getting enough. Your skin is really dark and you live at the North Pole. You have celiac disease. You're taking a medication like phenobarbital that causes your liver to break down all of the vitamin D that you get from your diet. So, moving on, I want to talk a little bit about peak bone mass. This is important. You need to know that peak bone mass was reached between the ages of 18 and 25. And the factors that affected it were your genetics, your endocrine and nutritional status, the degree of physical activity, and actually just living under gravity. So we know that when astronauts on the initial space missions came back to Earth, in that anti-gravity environment, they had lost significant bone mass. That's why they have such a disciplined exercise regimen for themselves now when they're out in space. So, The main clinical point that I think I can make to you over the course of this whole talk about osteoporosis is that patients don't come in complaining of osteoporosis. It's something that we have to think about as preventive medicine, health promotion, disease prevention. It's something that we have to put on our mutual agenda for our patients. So now we're going to have 6 slides that are going to be a little listy of osteoporosis and fracture risks. So let's see if we can talk them through without you falling asleep. Hypogonadal states will do it. So anything like menopause or athletic amenorrhea, which we'll talk about in the repro unit a little bit, will put you at risk for osteoporosis and or fractures. Other kinds of endocrine conditions like diabetes. Diabetes is a significant risk factor for osteoporosis, as is hyperpara, which we talked about, and thyroidicosis. Factors that cause or contribute to osteoporosis and fractures that are lifestyle choices. A lot of caffeine. Even if you're putting milk in your coffee or cream, the caffeine is still sucking the calcium out. Anything that's carbonated, anything that's an acidic environment, well, I just think of it as making the bones kind of the hydroxyapatite kind of bubble away from the collagen matrix. Immobilization, high salt intake. Genetics. There are a lot of genetic conditions that can cause osteoporosis or fractures. Significantly osteogenesis imperfecta, and we'll talk a little bit about that. When we're thinking about ethnicity, 20% of Caucasian and Asian women are over 50 are estimated to have osteoporosis, while only 10% of Latinas and 5% of African American women. So that's an indication that there's some genetic component to this. Gastrointestinal conditions, we already talked about how poor nutrient absorption, especially of things like vitamin D, would predispose to brittle bones. Think also about some hematologic conditions like sickle cell disease. So just FYI, the ones that I underline in general tend to be the ones that are either most common or just I find most interesting. Really interesting here, really important are medications. So this is the second I in vindicates. This is iatrogenesis. This is us potentially causing problems to our patients. And just like I said, patients don't usually come in complaining of osteoporosis because it's asymptomatic until you have a fracture. When we have patients on these medications, we need to anticipate that they are at risk for osteoporosis. We need to be bringing it up, talking about vitamin D supplementation, talking about checking their bone density. So anticonvulsants, glucocorticoids, immunosuppressants, chemotherapeutics, many psych meds, including lithium and SSRIs, which are very commonly used, anticoagulants, gonadal suppressants, even reflex medicines, which again are super, super common. These are all putting patients at risk for osteoporosis, and the actosavandiatide medications for diabetes, and we already said diabetes independently is a risk factor for osteoporosis. Something to keep in mind for these patients. Here are some further disorders like rheumatologic and autoimmune diseases, lupus, RA, HIV, and then just miscellany, alcoholism, COPD, and of course COPD is often treated with steroids, CHF, and any end-stage disease. So when you're talking end-stage renal disease, we call it renal osteodystrophy, what happens to the bone, end-stage liver disease. All right. We did it. We got through those 6 slides of listy lists of things that should start signaling you to think about the risk of osteoporosis in your patient. So osteoporosis is usually just a primary thing that happens because of genetics, age, your hormonal profile, etc. Sometimes, though, it's secondary to a very specific condition, for instance, hyperparathyroidism. So for a patient like that who's presenting with osteoporosis secondary to a different underlying condition, we definitely want to find out about that underlying condition so that we can treat it. Don't just leave them with that hyperfunctioning parathyroid gland. In postmenopausal women that present with osteoporosis, we can assume it's primary osteoporosis. But if you're seeing a man, especially a younger man, or a woman who's not yet menopausal, and they have osteoporosis, you might want to think about looking for an underlying trigger for the osteoporosis. So think about the main categories. Is there a chronic medical or systemic disease that's going on? Is there an endocrine or metabolic disorder that they have not yet been diagnosed with? Are there medications or nutrition that we can intervene with to help them? So if we think that there might be something underlying our patient's osteoporosis, how are we going to investigate? How are we going to start the search? Obviously, history and physical. And most of the time, we're going to want to order these tests above: a CBC, calcium, mag, and phos. We'll want to check renal and liver functions, etc. Definitely check a vitamin D level, thyroid functions, and PTH. In men, we'd consider testosterone and gonadotropins. These other tests below, looking for Paget's disease, multiple myeloma, etc., we would be prompted to look for if there was something specific pointing us in that direction. So I want you to think about somebody who had childhood rickets. Guess what? They're at risk for osteoporosis because the peak bone mass that they achieved was already low. Somebody with an eating disorder, they're absolutely at risk, not just for osteoporosis, but osteomalacia. And they had a low peak mass as well. Say you were 30 and you had bilateral oophorectomy. You weren't put on hormone replacement therapy, so that was surgical menopause. You are at risk for osteoporosis/fractures. Your mom and grandma both have that little kyphotic hump. That could be familial. You could be genetically inclined. What about somebody who has benign paroxysmal vertigo? Are they at risk for osteoporosis? Not necessarily, but they certainly are at risk for a fall, and that puts them at risk for fractures too. So I just want to keep encouraging you guys to think not just about osteoporosis itself, but about fractures and other risks for patients. A word about corticosteroid-induced osteoporosis, because they love to ask about this on the boards. You are at risk for osteoporosis if you're taking 5 milligrams of prednisone a day for 3 months. That seems to be kind of a cutoff. For some people, it's probably less. For some people, more. There are numerous mechanisms by which corticosteroids induce osteoporosis, and they include the following: decreased osteoblastic action, increased osteoclastic resorption, secondary hyperpara because your GI tract is not absorbing calcium as much. You can see altered gonadal function and decreased adrenal production of androgens that are also putting you at risk. And for falls themselves, glucocorticoids, we know that they cause a myopathy and a weakness in the muscles. So here's a question. For a patient with a glucocorticoid-induced osteoporosis, what would you expect to see in their labs? Would you expect their DEXA score to be up or down? We haven't talked yet about DEXA scores, but it's a way of measuring bone mineral density. So that's going to be down. What about their serum PTH level? We just said you can see a secondary hyperparathyroidism. So the serum PTH level may be up, but the calcium and phosphorus somehow are usually normal. What about the urine NTX? Remember we said that that was a sign of increased bone turnover. I would expect that that might be up for a patient who's got that secondary hyperpara happening. And what about a serum vitamin D3 level? Would you expect it to be up or down? We said that steroids can cause decreased gastrointestinal absorption of vitamin D3, so we might find that that level would be down. Which of the following is least likely to increase the risk of osteoporosis? Being on glucocorticoids, we know that's a risk. Anticonvulsants, that was one of the class of medications that I tried to emphasize puts people at risk for osteoporosis. Sulfonylureas were not specifically mentioned. Loop diuretics, they can cause renal calcium wasting. And proton pump inhibitors, certainly. The correct answer is C. Sulfonylureas do not have a direct known effect on bone mineralization. Although most osteoporosis in women is primary and idiopathic, which of the following cause secondary osteoporosis? Does hypoparathyroid? No. Multiple myeloma? Yes. Higher bone turnover for sure. Estrogen use is protective against osteoporosis. Hyperlipidemia, not known to be associated with osteoporosis. All right, let's move to talking about screening for osteoporosis. As we know, the principles that drive any screening for any kind of condition are, if we find this disease, do we have a way of treating it that improves outcomes? So this slide has a blue triangle. This is a very important slide. These are the screening guidelines as released from the National Osteoporosis Foundation and on who we should screen for osteoporosis. Bottom line, women over 65, men over 70, any adult that has significant risk factors like a low trauma fracture in their history, loss of height, or long-term glucocorticoid use, and any adult who has this fracture after age 50. How do we screen? Well, we're measuring bone mineral density as a surrogate. What we really care about is bone fragility. And we use the following technologies to do this. We do a DEXA scan, and that's the gold standard. These other technologies are available, but let's talk about why they're not as good. So DEXA scan is the current gold standard. We use a central measurement at the lumbar spine and the proximal femur. Sometimes we'll measure a peripheral at the calcaneus or the ulna, but those sites are not as sensitive to early changes and changes due to drug therapy, and they're not considered the gold standard. It's the central DEXA that's considered the gold standard. Test question. And what are the limitations? It's a two-dimensional test. It can't correct for body size, so small people tend to be underestimated. Bone spurs can falsely read as increased bone mineral density. Patient positioning, any inconsistencies with the different machines can all give some variability in interpreting results. What about the other technologies? There's a quantitative CT, and that is actually the only three-dimensional technique that's out there. It can provide a true measurement of density. We should be using it, but we don't because there's greater radiation exposure, and it's more expensive. It's simply not practical. Ultrasound would be lovely. It's a lot more mobile than these big DEXA machines, less expensive, no ionizing radiation, but again, it's still just not considered the gold standard. We don't have enough data about standardization and predictability with these results. What about plain x-rays? Can we find osteoporosis on a plain x-ray? Absolutely we can. But I want to let you know that once the osteoporosis is advanced enough to be detected on a plain x-ray, it's not a screening. We're not finding it at a point where we can intervene effectively. It doesn't make sense as a screening tool for population-based analysis. So it's often seen as an incidental finding. Somebody comes in with what you suspect is a compression fracture. You see osteoporosis clearly on the plain film. Fine, they earn themselves a diagnosis of osteoporosis. But again, it's not a screening method. So we're not going to send every woman over 65 and every man 70 and old for a screening plain film to try to find early bone mineral density changes that we can intervene with. So women greater than or equal to 65 years, men greater than or equal to 70 years, adults with risk factors, go back, remember what those risk factors are, or adults who have had a fracture, not just a low trauma fracture, after age 50. So which patient of these below should be screened for osteoporosis and why? What about a 58-year-old African-American female with rheumatoid arthritis for the past 25 years? Also, surgical menopause at age 43. Should you think about screening her? She's only 58 years old. She's only 58 years old, but she had RA, she likely got steroids, and she had early menopause. She's got plenty of risk factors. It's worth screening her. What about this 68-year-old male who was treated for prostate cancer? One of those med classes that we listed as a risk factor were chemotherapeutic agents, weren't they? So he isn't 70, but he's over 50 and he had chemo meds. I would screen him. What about a 53-year-old female? She's a longtime smoker. She's had COPD exacerbations maybe 4 to 6 times a year. They usually have been treated with a course of steroids. Well, this lady is young. She's only 53. But she is over 50 and she has the 2 risk factors of COPD and steroid exposure. I would screen her. What about this woman? She's 54 years old. She's this male, 54-year-old diabetic male on dialysis the past 6 years. He's young. He's barely over 50, but diabetes and dialysis are significant risk factors for osteoporosis, renal osteodystrophy, vitamin D deficiency, sedentary lifestyle. All of those would prompt me to want to screen this gentleman. Let's move from screening and start talking about treating. So when we think about treating osteoporosis, we take into account treatment guidelines, our own clinical judgment, and lastly, but most important, is the patient preference. So, what is this FRAX thing besides a really cool word because it's got an X in it? This is an algorithm that we use when we're measuring bone mineral density with our DEXA scan for our patients that helps us predict a fracture risk better than just using bone mineral density alone. It mathematically can help us see the 10-year probability of a major osteoporotic fracture. So if the probability for a hip fracture in the next 10 years is over 3%, probably want to talk to our patient about treating. If they're at risk for any other major osteoporotic fracture besides hip fracture of over 20%, let's talk about treating. What are these risk factors that this FRAX is taking into account? It's looking at your age, your gender, if you've had a prior osteoporotic fracture, if your femoral neck bone mineral, the degree of bone mineral density in the femoral neck, your BMI, whether you've taken oral glucocorticoids, presence of rheumatoid arthritis, secondary osteoporosis, etc., current smoking, alcohol intake. All of these things fit right into the algorithm and it pops out a number that's really helpful. You can use it in men and women from the ages of 40 to 90 if they have not yet been treated for osteoporosis. If they've previously been treated, the FRAX is not relevant for them. So, who should we treat? We should treat postmenopausal women who have had a vertebral or hip fracture, if they have osteoporosis by definition of their T-score, or even if they have osteopenia plus a FRAX score that's putting them at significant risk. Also, premenopausal women who have had a history of fragility fracture of the hip or vertebra should be treated, and men who meet the diagnostic criteria for osteoporosis should also be treated. Let's talk through a case study. This is Mrs. W. She's a 68-year-old smoker who presents to clinic with severe back pain. Sudden onset, started 5 days ago. She's been coughing up some morning phlegm. She experienced all of a sudden very sharp pain in her mid-back. She says the pain is a 7 out of 10. She describes it as constant, sharp, and non-radiating. She says she does not get any significant relief with Tylenol or Advil. She's had less appetite since this incident, the sudden onset of pain, but she does continue to smoke a pack or 2 a day. So her past medical history is significant for tobacco abuse, 50-pack year history. She's got COPD, of course. She's postmenopausal and she's never been on HRT. And here's what her MRI looks like. This is a compression fracture. All she had to do was cough. and she got this compression fracture. That's what happens when your bone is brittle. So let's talk a little bit about osteoporosis prevention, and you can see that these bones are exercising on the elliptocycle. So this is the pyramid for prevention and treatment. It starts with, at the bottom, at the foundation, lifestyle changes, addressing secondary factors, and then lastly, at the very tip, pharmacotherapy. And Dr. Lin will talk about that. So let's start with prevention. You want to try to maximize bone density early on and minimize bone loss later. Prevention starts in adolescence. So when you're doing those HEDS visits for your kids, you want to really talk about exercise, calcium intake, etc., especially for postmenopausal women and older men who you want to talk about any and all interventions that we can do to not just maximize bone mineral density, but to reduce their fracture risk. So sometimes this means counseling patients to avoid the things that strip the minerals from their healthy bones, like tobacco, alcohol, and caffeine. We want to talk about adequate intakes, particularly of vitamin D. We used to really focus on calcium supplementation, and we focus less on that at this point because we know that actually it's kind of tough taking calcium, and that if you are vitamin D replete, you can absorb adequate calcium from a healthy diet. What many of us are actually depleted in is vitamin D. So a lot of us are starting to shift our focus from calcium supplementation to vitamin D, and widening our focus to include other minerals and vitamins that are important for bone health, like vitamin K and all those other minerals we talked about before. We really want to emphasize weight-bearing and muscle strengthening exercises. Fall prevention in the home. This is something that I get really excited about. You might even order an occupational therapist or a physical therapist who does this kind of evaluation to do an in-home evaluation. You're looking for carpet edges that come up that people can trip over. You're looking for adequate lighting. You're looking for a safe path from the bed to the bathroom when you get up to go pee in the middle of the night. You want to make sure that their vision is good, that their hearing is good. Always, always review their medications, especially for ones that can increase dizziness and compromise vision. Anticholinergics, I'm talking to you. So again, vitamin D, this is a really interesting area right now with lots of shifting in what the consensus is. So we used to think, oh, if your vitamin D level is like over 20, you're fine. Now we really want to see what we consider a normal level is actually over 30. Recommendations about intake can vary, but there's really consensus that at least 1,000 international units daily of vitamin D3 for 2,000 if you're over 65 are most recommended. Calcium, the Institute of Medicine is still recommending calcium supplementation in these quantities. And here's what I want before I mention that calcium is actually hard to take, and this is what I meant. The pills are big, and then they make these calcium chews that are sweetened and that are funner to take because it's candy basically. But fiber can decrease calcium absorption. Calcium may decrease the absorption of these minerals, caffeine and sodium, increase urinary calcium excretion. What else do I want to point out to you on this slide? If you're on proton pump inhibitors, you can't use calcium carbonate because you need acid to be able to absorb that through the stomach. So you have to be taking a calcium citrate form of it, which is a little harder to find. You got to really read the label. Also, if you're on a bisphosphonate for osteoporosis treatment, you have to leave at least 30 minutes between the time you take your calcium supplementation and your bisphosphonate. So here's just a question. How can we be so dang mineral deficient when Americans eat so much? The American diet is actually higher in dairy than almost any other culture, yet we continue to be calcium and vitamin D deficient and have higher rates of osteoporosis. So there are a lot of reasons thrown out to try to explain this. I think there are a lot of anti-nutrients in our diet, things that interfere with calcium absorption. Some people feel we're refining the minerals out of our food and farming the minerals out of our soils. We have nutrient imbalance. So you can take all the supplements you want, but your body is going to still try to balance the calcium and the phosphate and the magnesium. And if you're not getting the right balance of all of these, you're just going to be passing some of those supplements right out your urine. We have a very acidifying diet. This is not the appropriate cellular milieu within which bone mineralization occurs optimally and results in the best bone architecture. So those are some ideas. Just wanted to let you know what some of the thinking is out there in the medical community. The integrative approach, again, I'm not putting a blue triangle here. This is just me speaking to those that are interested in these topics. Instead of focusing so specifically on the bones themselves, we really want to think more about strengthening the organism. So we think about intestinal integrity, making sure that the patient is getting the right content in their diet, and also that the intestines are healthy enough to appropriately absorb the nutrients that they're getting. In traditional Chinese medicine, we think about the relationship between the bones and the kidneys. They're very connected. So anything that nurtures the kidneys is going to help them do their very important function of balancing calcium metabolism. And then again, thinking about things like boron, magnesium, zinc, silicon, vitamin K, strontium. These are all, actually strontium is used kind of first line for osteoporosis in Europe. It is not yet approved in the States. So some powerful dietary prescriptions would be things like bone broths. And we're seeing a lot about it in the popular media nowadays too, about bone broths. Greens that have lots of calcium, that's a lot more bioavailable than it necessarily is in a pill or supplement. Especially beans that are soaked to get the phytic acid out of them. And if you're interested, we can talk more about this. Seaweed is a great source of minerals, and especially tonifying to kidney yin. So moving away from the integrative medicine approach, let's talk briefly about the FDA-approved pharmacologics, because Dr. Lin will be talking much more about these. We have three main approaches. We've got the anti-resorptives, mostly the bisphosphonates that we're talking about. We've got the anabolics, which are bone-forming, parathyroid hormone. Wait, we said parathyroid hormone is osteoclastic. It breaks it down. I know, it's crazy, and yet this is... it doesn't work that way when we're using it as a pharmacologic. So I'm going to leave the rest of that to Dr. Lin, and I'm going to move on with a case study. I want to talk to you about my friend Dalbir Khalsa works with me at the Petaluma Health Center. If any of you rotate up there, you might meet her. At the time, this was a few years ago, she was a 55-year-old female of Ashkenazi heritage with known and untreated osteopenia. She is very active. She hikes and dances, skis. She sustained a right hip fracture with a low-velocity fall. So, unremarkable history. She was never a smoker, no significant risk factors, and she's a physician assistant. She had this fall. She was evacuated off the mountain. She had a hip fracture. She underwent open reduction and internal fixation. 3 pins were placed, and immediately she got mobilized and rehabbed and did great. Her DEXA was repeated, and it showed a score that earned her a diagnosis now of osteoporosis. But her PTH was normal, and the rest of the workup for secondary causes. Remember, she was only 55 at the time. So we have right hip fracture, status post open reduction and internal fixation, and primary osteoporosis. She was prescribed alendronate, and she took it for 2 months, and then took herself off. She wasn't having side effects, but she knew that as her fracture was healing, the idea of the effect of the alendronate on her bones didn't sit well with her. She was also supposed to be taking calcium. She stopped it because it caused constipation. So this is a PA. This is a medical person. She chose to increase her exercise level, and she took vitamin D until her level was over 30. The pins in her hip were causing her pain. She had them surgically removed a year and a half later. She didn't have any further symptoms. And at the time that I put this slide together, she wasn't on any meds or supplements. She didn't have a follow-up DEXA or even a urine NTX. Why am I talking to you about this? Dalbir is not alone. Compliance at 6 months with the bisphosphonates is about 50%. Why? Lots of different reasons. Maybe negative opinions, misunderstandings. So as I beat this drum all the time, really patient-centered counseling and motivational interviewing is, I think, the key to improving compliance. And we're going to talk more about that, and we have a standardized patient lab where you'll get a chance to practice doing motivational interviewing later this year. So once we make the decision to put somebody on therapy, how do we monitor their response? Well, we can do another DEXA scan, but what's the time interval that it takes to see actual change? We have to wait 2 years. So that's a long time to kind of just be taking your medication on faith that it's doing something good for you. What some of us are doing in clinic is doing a urine NTX. Remember, this is a biochemical marker of bone turnover. We'd expect it to go down if the bisphosphonate is working. And we can wait 3 months, more commonly 6 months, to see if there's an effect. So obviously that satisfies our curiosity, and it's becoming an increasingly popular tool. So in summary, here are the key points about osteoporosis. Osteoporosis-related fractures are really common. We counsel patients preventatively about the risks and the importance of diet and exercise. We screen women 65 and older. We screen men 70 and older. We screen people younger if they have significant risk factors. Our best guess is that screening intervals of 4 years are good. We do repeat a DEXA for response to treatment after 2 years, and we can do a urine NTX sooner. The lab eval for newly diagnosed osteoporosis includes a CBC, calcium, mag, and phos, renal and liver functions, TSH. We're looking for vitamin D3 levels. We're looking for PTH. Further evaluation is indicated if secondary causes are suspected. First-line treatment is fall prevention, smoking cessation, moderate alcohol intake. So again, the non-pharmaceuticals are always your first line, and bisphosphonates if you meet criteria. Consider discontinuing the bisphosphonates after 5 years if there's no vertebral fractures, and again, there are no fast and firm guidelines around when to discontinue bisphosphonates if there's added benefit of continuing them past 5 years. So moving away from osteoporosis, let's talk a little bit about osteonecrosis, rickets, osteomalacia, Paget's and osteopetrosis, and osteogenesis imperfecta. What is osteonecrosis? Osteonecrosis is a bad dude. This is aseptic necrosis, a bone infarction, or avascular necrosis of the bone. It's probably the term you'll hear the most, avascular necrosis. This is a compromise of the bone vasculature leading to death of the bone and the marrow cells. So the common sites are going to be places like the femoral head, the talus, the scaphoid. Femoral head is where I've seen it the most. There are many causes, most significant among them glucocorticoids. Interestingly, bisphosphonate use and osteonecrosis of the jaw is ironically a risk factor. Patients will present with pain. So this jaw thing, it's not a normal site. It's not a common site for osteonecrosis. It's been kind of surprising that bisphosphonate use is associated with it. I think Dr. Lin will speak about it a little bit. So osteonecrosis presents with pain, bad pain, bone pain. You can image, even just plain films will often see it, but you might have to do a bone scan or an MRI. Treatment depends on how progressed it is. It may require joint replacement. And a friend of mine's father just underwent some significant reconstructive surgery to his jawbone. He's a diabetic who was on bisphosphonates and suffered osteonecrosis of his jaw. Very complicated, somewhat deforming surgery to try to address that. Okay, rickets and osteomalacia. So distinct from osteoporosis, where the ratios of osteoid to hydroxyapatite are maintained, rickets and osteomalacia represent defective mineralization disorders of the bone. So instead of brittle bones, these are soft bones. Rickets describes the condition in childhood, and if this happens after fusion of the epiphysis, it's called osteomalacia. Very painful. So initial manifestations of rickets, they come at the sites where the bone growth is most rapid. Are you noticing that this little kid's legs are very bowed? Are you noticing what's happening at the radial styloid right there? With a bone condition like rickets, the first place that we'd expect to find findings would be in the skeleton. I have a friend, Dr. Kanane, who is from a small village in the north of Israel. He studied in medical school in the States, and he told me how when he was learning about rickets, and they talked about this frontal bossing and this rachitic rosary. The rachitic rosary is these knobby costochondral junctions like a rosary around the chest. And he noted these things on himself. It was then that he realized he actually had suffered rickets when he was a child growing up in this remote Arabic village with an inadequate diet. This lateral bowing of the femur and the tibia, it's important to recognize that starts to manifest once the child starts walking and bearing weight. So under the weight of their own body being upright, these soft bones start to bow and bend. But there are not just skeletal manifestations, there are extraskeletal findings in rickets as well. And I'll just share with you, I treated a case of rickets just a few years ago in California, so it happens in modern day. The patient was about 9 months old, and he was admitted through the ER with a pneumonia. Routine lab work showed that he was hypocalcemic as well. So this was a patient of mine from the clinic, and he didn't have any bowing of his legs. He wasn't walking yet. He had been exclusively breastfed through 5-6 months by a mom who wore full hijab, so inadequate sun exposure. She was vitamin D deficient and transferred inadequate stores of vitamin D to him through the milk. And now he was presenting with a pneumonia, and I thought, oh, how lucky he got the pneumonia, so we found this hypocalcemia before he seized. But actually, vitamin D has arguably as important a role as vitamin A in immune status. So it wasn't just luck, it was actually probably causative that he was predisposed to pneumonia and serious infection because of this low vitamin D. So what we actually ended up doing was putting him on a helicopter and sending him to Children's in Oakland, because as you start repleting calcium, as you start repleting vitamin D, the bones get so hungry for it that they soak it all up from the plasma, and you can drop your calcium quite precipitously and wind up with seizures. So the way that this has changed my practice is I'm much more aggressive now about offering vitamin D supplementation to all my breastfeeding moms, especially those that don't eat liver and don't spend a lot of time naked in the sun, which is kind of all of us. We're all significantly at risk for vitamin D deficiency. So the most common cause of rickets is inadequate vitamin D, but there are other potential issues as well. So inadequate nutritional intake of vitamin D, but what about inadequate gastrointestinal absorption. Speaking about osteomalacia, these patients often have painful proximal muscle weakness in addition to the bone pain and bone fragility. And here's what you might expect to see in the lab work. The alk-phos might be up, indicating bone turnover. Calcium might be low. They might be urinating out more calcium than you want them to. And the phosphate may be low. The parathyroids might be secondary hyperpara, so you might see it up. How do we treat rickets and osteomalacia? Well, figure out what's missing from the diet and replace it. Watch for that hungry bone syndrome I mentioned when vitamin D treatment begins. The approach depends on the outcome of the workup that you do for underlying etiology. And remember, be careful when we're replacing vitamin D. It's one of the fat-soluble vitamins. It can lead to toxicity, and although it's rare, like I said, this is something that's really in the zeitgeist right now. People are talking about it a lot. Some people are really aggressively supplementing their vitamin D. So we have seen some vitamin D toxicity, and it will manifest with hypercalcemia, poor appetite, nausea, vomiting, weakness, excessive urination, constipation. Moving on to Paget's disease of the bone. It's also known as osteodystrophia deformans. This is a condition that's associated with accelerated bone turnover, resulting in disorganized and structurally compromised new bone. So this is an example of bone turnover happening at a rate and in a way that is not actually building healthy, fresh bone. Structurally compromised. There are probably a few different etiologies, genetic, possibly paramyxovirus related, and we tend to see three phases in Paget's disease. You see that osteolytic phase at the beginning, where there's bone resorption and hypervascularization to the point where the bone might even feel hot under your hand. Then we see this remodeling, this active and hyperactive and disorganized bone remodeling. Lastly, the final phase, you see sclerosis of the bone. Resorption declines, and you're left with this dense, hard, less vascular bone that we call Pagetic bone. And this, on this upper left-hand X-ray, is that characteristic appearance of this Pagetic bone. The bones that are most commonly affected in decreasing order. First, the pelvis, which is why I put that picture of the pelvis up there. Then femur, skull, and you saw in that first picture, the gentleman, his skull was clearly affected. And you might have also noticed, if you're an eagle eye, that he had a hearing aid in. So you may see, in addition to pain, which is the first symptom, deep aching bone pain, people might note some cranial nerve entrapment symptoms. So an increasing hat size, maybe decrease in hearing. Rarely, that first hyperdynamic phase may be so dramatic that you might even see high output heart failure. Fractures can occur in these long bones at areas when it's in that active lytic phase. Increased bone formation and calcium requirement can lead to secondary hyperpara in 10 to 15%. And then it's rare, but it's a significant thing to think about. There might be sarcomatous changes in up to 3% of cases. So some of the findings in lab, you might see a normal calcium and phosphorus, but the bone turnover markers like alk-phos and urine NTX will be significantly elevated. The X-rays will show that the affected bone is expanded and denser than normal, and there may also be radiolucent areas of bone loss interspersed, especially in the skull, so you'll see this mosaic effect. And if you look in the frontal area, the bone is less dense. In the occipital area, the bone is super dense. So again, here with this gentleman, you see the frontal bossing. You see some dilated scalp veins and nerve deafness. So how do we treat Paget's? We treat for only if they're having significant pain, hemodynamic or neurologic compromise. We use bisphosphonates because they decrease bone turnover. Usually we'll do a cyclic regimen. So the second to last condition I'm going to mention to you is osteopetrosis. Osteopetrosis are these petra, meaning stone. These bones are dense, and it's caused by a group of genetic disorders that impair osteoclastic resorption of the bone. So you have a lot of bone formation and not enough actual turnover. And the presentation can look a lot like Paget's. You have this thick bone stenosing the cranial nerve outlets, compromising hearing and vision potentially. You might see fracture, or early on you may see hypocalcemia. The treatment is bone marrow transplant. And lastly, osteogenesis imperfecta, which you've already heard about elsewhere. Just remember, this is a problem with the collagen structure. The hydroxyapatite matrix is also compromised because of its relationship to the collagen scaffolding of the bone. There are a few different subtypes, autosomal dominant inheritance and some rare de novo mutation. In the most severe forms, we can see intrauterine fractures. We see the blue sclera, and you'll probably see some boards questions on OI. Again, always remember about the suspicion of non-accidental trauma for these patients. That ends our bone talk. Thanks so much for your attention, and I'm sorry I'm not there with you guys in person. I hope you all had a great Thanksgiving.